discussing a stepwise approach to minimize endothelial damage in cataract surgery. So basically there are two aspects here: normal routine cases that we do and also cases which have a low endothelial count. So just a quick recap of the anatomy of the cornea. So as we all know, the endothelium, which is the innermost layer, has a very vital role to play to protect the cornea and its clarity. The endothelial pump activity keeps the cornea dehydrated and clear, and we have a finite number of cells in the endothelium. So I just wanted to touch upon the stroma. Everybody talks about the epithelium and the endothelium, but we tend to ignore the stroma, which also has a very important role. So 90% of the cornea is the stroma, and we have approximately 200 lamellae with the keratocytes dispersed in between. And the orientation of this lamellae actually play a role in which, how we see the corneal edema. So there is more branching and intertwining of the lamellae in the anterior one-third of the cornea. That means the anterior one-third is more strong, and the posterior two-thirds of the cornea, it has got more parallel lamellae, and there is more hydrophilic proteins in the posterior stroma. So what happens is when the cornea gets edematous, the anterior lamellae will take up the stress. It will maintain the structure, and the posterior fibers will become lax, which will get visualized as stromal folds and also as DM folds, what we see on the slit lamp. So come quickly, recapitulating the physiology, how it is maintaining its clear state. So basically there are 5 factors which affect the corneal transparency: the stromal hydration pressure, the epithelial barrier, endothelial pump, tear evaporation, and also the intraocular pressure that plays a role. So why do we need to protect the endothelium? So we know that there are a lot of tight junctions and adherence junctions, and there are these sodium potassium ATPase and bicarbonate dependent ATPase, which counteracts the water imbibition into the stroma. So now these endothelial cells are a finite number, and the cells which are lost, the other cells will just cover up, they'll enlarge in size and cover up that area. So the loss or damage to these interconnected cells results in increased water imbibition into the cornea. So we have the endothelial cell count, which is around 3,000 to 4,000 at birth, and there is an attrition every year. And the critical number will be 500 to 700 cells. After that, the cornea will decompensate. So we have some diseases like the Fuchs endothelial dystrophy, then the ICE syndrome, where the counts are going to be low to begin with, and it may have a very damaging effect during your cataract surgery. So we need to be careful here. So what happens during cataract surgeries? There is a mechanical trauma to the cells due to manipulation, also the thermal effect because of your phacoemulsification, chemical effect because of the medications that we are using intraoperatively. So this causes an accelerated loss of the endothelial cells, especially in old age, dense cataracts, patients who are already on anti-glaucoma medications, they are more at risk. So let's have a look at a stepwise approach. So first we need to identify vulnerable patients. Intraoperatively, what precautions we can take, and postoperatively, how do we manage it? So preoperatively, a careful examination on the slit lamp will give us clue. Now, these pictures are very, very in the face, showing a lot of guttae, but sometimes we will have very few guttae, which you may miss. So it is very important that when you are seeing the slit lamp, just don't directly focus on the lens. What happens is we tend to directly look at the lens. Okay, this is a grade of cataract, this is AC shallow, not shallow, done. We forget to see the endothelium. So I think it's very important we assess that. Keep in mind how dense is your cataract, is the AC shallow, what is the specular count, and especially patients who have had long-term glaucoma medications, they are also vulnerable to have a weaker endothelium. So intraoperatively, what will help is, first of all, minimal manipulation with instruments. So, the side ports, the main one that we make, we have to be careful with the way we enter so that we don't damage the Descemet's membrane. Use a low flow, low IOP phacoemulsification that will cause minimal turbulence within the AC. Also use of torsional phaco systems, they say, have less turbulence or chatter, which will prevent damage to the endothelium. And using the appropriate viscoelastic, again a very important point. So as Dr. Ambika was mentioning, again the soft shell technique becomes very important over here because the dispersive OVD will go and coat the endothelium, and the cohesive or adaptive viscoelastic, which is in the center, will help us to do all the maneuvers that we want to do. So we need to protect the endothelium with a good dispersive viscoelastic, which will stay there, minimizing the damage to the endothelium. So I think I already told about this. So keeping the infusion off while entering the eye, that is very important because that prevents your DM getting sloughed off. Use disposable single blades to avoid DM detachment. Careful during hydration and judicious use of the phaco energy. Staying in the safe area. I'll come to the videos. Are both playing? Yeah. So here if you can see, you take your time, make your side ports well. When you go and make your main wound, be slow and gentle and keep an eye on the endothelium. So that endothelium and the DM, Desmond memory, which is a thin transparent structure which you may miss seeing that you have, sloughed off. Also when you are entering for implanting your IOL, be careful that you are gentle over there and hydration of the wounds. If you look at the second video, I'm doing a hard cataract over there. The phaco tip should remain in the center of your wound. Sometimes we forget and it is nudged at the edge and it can cause a very bad wound burn. I'll come to wound burn next. Here, when you're doing the phaco, ensure that the pieces don't go and hit the endothelium. Use your second instrument to keep the pieces down. And if there is chatter, then see your phaco settings, whether they are proper or not. Now, when you're entering with your bimanual, keep the infusions off. Don't keep them on initially because that can, damage the side ports. Just touching upon hydration. When you hydrate the wounds, go and hydrate the walls. I usually avoid hydrating the roof because that is the time when you can, go and cause a DM detachment over there. And if you're noticing a small DM detachment, then be careful that you put an air bubble. Okay. Do I have time or have I overshot the time? What is the... Okay. Yeah. So all of us want a picture like this on day one. We are happy when we see a clear cornea on for day one. We want specular counts which are, remaining almost the same pre-op and post-op. But sometimes we are disappointed and we have a picture like this, and we hope that we go from picture 1 to picture end in our journey of doing cataract surgeries. And I think what happens is sometimes there may be retained viscoelastic at the end of the surgery if you have not cleared off visco well, and what you'll have is there will be no stromal edema here, but there will be microbullae. So this is where there's just raised intraocular pressure and you need to give IOP lowering agents. Coming to DM detachment, if there's a localized detachment, localized corneal edema that you see more near the wounds, think of DM detachment. And the definitive way to know it would be to do a ASOCT. That will give you a picture whether there's a DM detachment. If there is a big DM detachment, you cannot just leave it alone. You'll have to go put in an air bubble or SF6 to help reattach it. Coming to wound burns, as I demonstrated in that video, you need to keep your phaco tip in the center of the wound. Sometimes what happens is if you are not aware of where you are, you may be hitting onto the side walls and the thermal heat will cause that area to have a burn. And if there is a burn, then the collagen, it shrinks and this wound will not oppose on its own. It will need multiple sutures to close. So this is a dreaded complication that can happen. You need to be careful here. Also, when there is a hard cataract, we tend to use a lot of viscoat or dispersive OVD. It has a thermogenic effect. Also, it can go and clog your phaco probe, and that leads to wound burns. Quickly telling about TAS. So this TAS is a rare thing, but it can cause limbus to limbus edema and inflammation in the anterior segment. It is because of the enzyme cleansers or preservatives, and it is basically a non-infectious cause, but it is very damaging to the eye. So coming quickly to the management. So if you see there is a lot of stromal edema that is there in post-operatively, then that is mainly because of the inflammation. So what helps here is the topical corticosteroids. Adjuncted to that is hypertonic saline or alignment that help to deturge the cornea. Rho kinase inhibitors also have a similar role, and if there is a raised IOP, please use anti-glaucoma medication that will help clear off the corneal edema. Coming to the surgical intervention, DM detachment, as I already told you about air bubble, SF6, sometimes suturing of the DM may also be required. Wound burn needs definitely a lot of sutures to close, and if the cornea has already gone into decompensation, then we need help of our cornea friends. Maybe go for a DM stripping, endothelial keratoplasty or a DMEC. Thank you.
Thank you, Dr. Vanashree, for highlighting how to take care of the corneal endothelium. So we've learned it through the years that it's very important to understand the corneal endothelium before starting the surgery. Actually, I would prefer doing a specular microscopy for every case, so that even if you have missed clinically, it's a way to pick up if the patient has a low endothelial count.